Good morning, afternoon, or evening, wherever you are watching this from today. I'm Roger Fielding from Tufts University in Boston, and I'm pleased to welcome you to our webinar, Sarcopenia in Clinical Practice. This webinar was organized and facilitated by ILSI US and Canada. Partners for Advancing Clinical Education is the joint provider of this activity and oversaw its accreditation. After watching this webinar, please complete the evaluation form on the webpage to receive your certificate for continuing education units. This activity provides CEUs for physicians, PAs, nurses, registered dietitians, and social workers. The purpose of this webinar is to raise awareness of sarcopenia to improve its prevention, diagnosis, and treatment. Therefore, the learning objectives are to define sarcopenia and describe its diagnostic criteria, including clinical indicators of low muscle strength, mass, and physical performance. Identify patients at risk for sarcopenia using validated screening tools and clinical judgment. Implement evidence-based lifestyle interventions, including physical activity and nutritional strategies to prevent and manage sarcopenia in diverse patient populations. And finally, to review the latest research on sarcopenia to enhance patient outcomes. We have three speakers today, myself, Roger Fielding. Our first speaker is Dr. Rose Ann Kenny, the Regis Professor of Medicine and Chair of Medical Gerontology at Trinity College Dublin. She is also the founding principal investigator of the Irish Longitudinal Study on Aging and director of the Mercer's Institute for Successful Aging at St. James Hospital. We also have Dr. Stuart Phillips with us, who is a professor in the Department of Kinesiology at McMaster University and holds a Tier 1 Canada Research Chair in Skeletal Muscle Health in Aging. He directs the Physical Activity Center of Excellence and the McMaster Center for Nutrition, Exercise, and Health Research, leading the Protein and Exercise Metabolism Research Group. In this webinar, we will cover a wide range of topics related to sarcopenia. First, I'm going to set the stage a bit before handing it over to Dr. Kenny to walk us through how sarcopenia is defined, misperceptions, prevalence, and the public health burden of sarcopenia. Then we will cover diagnosis and treatment, and Dr. Phillips will discuss the role of nutrition and physical activity. He will end our webinar by sharing with us practice implications, including the impact that increased use of GLP-1 medications have on sarcopenia in the clinic, and provide some key takeaways. Finally, we'll have some time for some discussion during our fireside chat. Here's a little bit of background information about definitions, misperceptions, prevalence, and public health burden. Aging is a US and global reality. We expect that by 2030, 1 in 5 Americans will be age 65 or older. 1 in 6 people will be over the age of 65 by 2050, up from 1 in 11 in 2019. By 2080, persons aged 65 years or older will outnumber children under the age of 18. This demographic transition is occurring in both high and middle and low income countries. So this is a worldwide phenomenon. Impaired mobility and falls increase with age. Among individuals aged 65 plus living in the community, 39% had difficulty walking or climbing stairs, and 10 million were unable to do so at all. 1 in 4 adults report falling every year, and falls are the leading cause of injury for adults aged 65 plus. Deaths due to unintentional falls are a leading cause of unintentional injury among older adults, and the rates of unintentional fall deaths increased between 2000 and 2020 for adults aged 65 to 74, 75 to 84, and 85 and older. These data have led to an expanded focus on older adult populations in national guidelines. I'm now going to pass over the presentation to Dr. Kenny.
Thank you very much. I'm delighted to be here and welcome from wherever you are globally listening to this webinar. With respect to guidelines, guidelines exist globally to guide both diet and physical activity recommendations, and particularly for older adults in the context of today's topic. There has been a lot of progress towards meeting these guidelines and related national goals. And of course, that's constant, ongoing, and being monitored. And you can find links with respect to American guidelines in additional materials linked to the website. First of all, let's look at the dietary guidelines for Americans. In 2020, the Dietary Guidelines for Americans, or DGA, expanded its focus to include older adults, with recognition that this life stage is at greater risk for health conditions, particularly sarcopenia. They also focused on the relationship to dietary patterns and dietary intake. And it's noteworthy that Canada's food guide also gives specific recommendations for older adults. The second pertinent guideline domain is physical activity guidelines for Americans. And this provides recommendations on both the amount and types of activity that should be performed weekly. And thirdly, we want to bring your attention to Healthy People 2030. This provides targets for older adults, including prevention of falls and promotion of physical activity. And among the related goals for older Americans are decreasing fall deaths, which of note have been worsening. Now I'd like to introduce you to Linda. Linda is a 79-year-old woman who presents with complaints of increasing difficulty in performing activities of daily living, such as climbing the stairs and standing from a seated position. She describes herself as feeling weak and reports frequent falls over the past 12 months, with a noticeable decline in her ability to carry groceries and perform typical household chores. This has significantly impacted her quality of life, and she describes feeling embarrassed by her physical limitations and fragility. And as a consequence, she employs increasingly avoiding activities. For example, she avoids social situations where crowds are present, again out of concern for another fall. So consequently, she has been largely sedentary, with minimal physical activity over the years. So hold that case in mind when we go on now to the next slide with respect to the discriminating sarcopenia and cachexia and frailty. So let's go to now definitions: sarcopenia, cachexia, and frailty, three important domains that we need to be familiar with. And differentiating between these three and other common diagnoses in older adults is important. First of all, sarcopenia. Sarcopenia is an age-related syndrome characterized by progressive, generalized loss of skeletal muscle mass and strength, with the risk of adverse outcomes such as physical disability or poor quality of life, or of course, death. Now, unlike sarcopenia, cachexia is typically secondary to underlying illness and is associated with inflammation and chronic illness, and characterized by severe loss of body weight, muscle, and fat. And then finally, frailty. Frailty, a state of increased vulnerability to adverse health outcomes due to age-related decline in multiple physiological systems. And it is characterized by clustering of symptoms, including weakness, slowness, exhaustion, loss of weight or appetite, and reduced activity. The prevalence of frailty in the US is 10% for physical frailty and around 23% as measured by the frailty index, and we'll come on to that later on, which is a composite of physical, emotional, and cognitive measures. The frailty index is a cumulative deficit model, therefore. Sarcopenia is a difficult diagnosis, but it's important to remember these three characteristics which underpin the diagnosis: reduced muscle mass, decreased muscle strength, and a decline in physical performance and function. Of note, there is limited physician knowledge of sarcopenia in, for example, the US, in Canada, Australia, and the UK. In the US and Canada, less than 20% of internists and family medicine physicians report being familiar with the term sarcopenia. And nearly 35% report being not very familiar or not familiar at all. Over 75% report not typically using specific diagnostic criteria or being unsure if their approach utilized specific diagnostic criteria. An interesting concept, and also an important concept, is that of sarcopenic obesity, which is a simultaneous decline in muscle mass and function, along with high fat mass. And there's growing concern in older adults of the combined adverse implications for mortality and comorbidities in this frequently unrecognized group of patients. Couple of misperceptions. Is sarcopenia inevitable? No, it is not a natural part of aging. What about severity of muscle mass and strength loss? Well, everybody loses some muscle mass and strength as they age, but importantly, not to the extent seen in sarcopenia. What about the prevalence of sarcopenia? 10 to 40% in community-dwelling older adults, but it varies a lot by geographic region and age, ethnicity, and the setting of the population. It is higher, the prevalence is higher in long-term care and in acute hospital settings. And part of this variability in prevalence stems from how we define sarcopenia and how frequently those definitions are applied and operationalized, including methods used to measure muscle mass. And unfortunately, there's poor agreement also between different working groups and societies with respect to the definition of sarcopenia in population-based cohorts, which further adds to variability. Coupled with the fact that thresholds for gait speed and grip strength also vary. Public health burden. Given that the US population is aging and given the growing rate of mobility limitations, early identification and use of appropriate prevention and treatment strategies are actually critical to reduce the prevalence of sarcopenia. It's associated with a higher rate of mortality, particularly in people aged 79 and older. Threefold increase in functional decline. Significant increase in rate of falls and a higher incidence of hospitalizations. So sarcopenia carries a major public health burden. And contributes to this concept of a gap between lifespan, the number of years we live, and health span, That's the number of years lived in good health without disease or disability. And that gap has been increasing over time. On the left, you can see of this graph, you can see how it's increased from 8.5 to 9.6 years between 2000 and 2019. The global lag in health span compared to lifespan, present over 183 member states reported by WHO, averages about 9.6 years now. And in the US, mental and substance use disorders and musculoskeletal diseases contribute to most of the disease burden and years lived with disability. So pertinent to sarcopenia. Early identification and prevention are both very important if we're going to impact on this health span, lifespan gap and ensure early intervention and therefore prevention of further decline. All older adults, therefore, are at risk of developing sarcopenia and should be screened annually or after the occurrence of a major health event, such as, for example, a fall, which resulted in hospitalization. Identifying individuals with sarcopenia is what we mean by case finding. Screening, alternatively, is detecting early disease and risk factors in large numbers of apparently healthy individuals. And we recommend both screening and case finding for sarcopenia. So, what does the patient with sarcopenia look like, and what are the specific assessments that we should employ to address this syndrome? With respect to anthropometrics, we should look for unintended weight loss of more than 5% of body weight in under 6 months, or more than 10% in over 6 months. Evidence of muscle wasting. And measure calf circumference. With respect to muscle strength and performance, one of the other characteristics of sarcopenia, we should again measure muscle strength, difficulty walking or climbing stairs and or rising from the stairs, and take a good falls history. This is the SARC-F questionnaire, which covers strength, assistance with walking, rise from a chair, climbing stairs, and falls, and is used globally to identify individuals at risk of sarcopenia. For example, with strength, how much difficulty do you have in lifting or carrying 10 pounds? None, some, or a lot. How much difficulty do you have walking across a room with respect to A, assistance? How much difficulty do you have transferring from chair to bed or rise? How much difficulty do you have climbing a flight of stairs, climb? And how many times have you fallen in the past year, F? There are limitations. There are gaps in rigor and strength of evidence for a number of screening tools. This is but one. And the sensitivity of SARC-F varies across different studies. Unfortunately, there is overall a lack of common standardized methods for screening in large population-based surveys and in other studies, which limits screening. Next case to reflect on. This is Elizabeth, a 70-year-old woman. During a yearly visit to her primary care physician, she mentioned she had noticed having difficulty climbing the stairs in her house, standing up from a sofa and lifting her young grandchildren. The nurse completed the SARC-F questionnaire and informed the physician that she was at risk of sarcopenia. Elizabeth's doctor reviewed the questionnaire and advised the patient on the importance of consuming adequate protein in her diet and increasing physical activity, particularly strength-based exercises. And if we have a look here at Elizabeth's SARC-F questionnaire, again, S, strength, how much difficulty, etc., some. Assistance, difficulty walking across a room, some. Rise from a chair, yeah, some. Climbing stairs, again, some. And falls, none, yet. So her SARC-F score was 4. And a score of 4 or greater indicates an individual is at risk of sarcopenia and underscores exactly the nurse's impression. Now, I advise you not to click the link to watch the video. Participants can access the video in the additional materials linked to the website. Basically, the video shows how sarcopenia can be diagnosed by measuring gait speed, that's how fast we walk, and grip strength. Gait speed measures low levels of physical performance. Grip strength indicates the extent of muscle strength. And this is the Southampton protocol. There are a number of protocols. This is one. It's quite well validated. You sit the participant in a chair with the back support and fixed armrests, ensure the red needle is on 0, and support the weight of the dynamometer by resting it on the palm while the subject holds the dynamometer. But they shouldn't restrict the movement of the device. Encourage the participant to squeeze for as long and as tightly as possible. And when the needle stops rising, read the measurement and record the result to the nearest 1 kilogram. Disregard and repeat the test if the participant's arm rises above the arm of the chair or if their feet lift off the floor during the measurement. And record 3 properly taken measurements for each hand, alternating slides. And these are the accepted clinical cutoffs using the Southampton protocol, less than 35.5 kg for men and 20 kilograms for women. Low muscle mass. Now, low muscle mass can be identified by a DEXA scan or a bioelectrical impedance analysis. This is in clinical settings. However, there is not yet a widely accepted methodology for accurately measuring muscle mass that is a predictor for hard endpoints like mortality or physical performance. And very low muscle mass does help to identify issues that can be remedied, like malnutrition. And it's one of the most treatable components of sarcopenia. But again, there's as yet no clearly defined cutoffs established even for this. Okay, this is Anna. Anna is 50, and she works in it as an administrative assistant and does not exercise regularly. Her diet contains very little protein, and she has noticed she gets easily fatigued and has lost muscle tone in recent years. Her doctor discusses the importance of preventing further muscle loss as she ages and recommends that she increases protein intake by adding protein-rich foods to her diets like eggs or Greek yogurt or legumes or lean meat, poultry, beans and tofu, and protein shakes. And he also recommends that she increase physical activity, such as walking for 30 minutes a day during her lunch break, and also joining a community fitness class with resistance training. The medical team helps Anna understand how many calories she needs and daily amounts of different food groups by using a My Plate plan at myplate.gov, which we would recommend. Now I'm very happy to pass you over to my colleague for today, Dr. Stuart Phillips. Stuart.
Thank you very much, Dr. Kenny and Dr. Fielding. It's a pleasure to join you on this webinar. My tasks this afternoon are to cover the aspects of physical activity and dietary recommendations. I think we can all agree that the prevention of sarcopenia then includes the maintenance of muscle mass via regular physical activity. And in fact, if I had to prioritize, this would be my #1 recommendation. And particularly the incorporation of resistance training, which through prevalence data we know is not engaged in by a number of individuals. There are almost global recommendations for physical activity, but I'm going to focus on the physical activity guidelines for Americans, but the WHO guidelines are very much similar. And I think everybody would recognize that adults should do at least 150 minutes a week of moderate to vigorous intensity physical activity or exercise. But as part of their physical activity, older adults should also do multi-component physical activity that includes balance training, as well as aerobic and muscle strengthening activities. And it's the loss or lack of engagement in strengthening activities that is probably the #1 downfall for a number of individuals. So further, older adults need to determine their level of effort for physical activity relative to their level of fitness. And I think we can all appreciate that with aging, chronic conditions such as cardiovascular disease or cancer, for example, may cause or result in the ability or inability to be able to do some of these things. So the effect that these conditions have on the ability of older persons' activity is particularly important. So people who cannot do 150 minutes of moderate intensity activity or strengthening activities should be as physically active as their bodies allow and their conditions mandate. And if they need to seek the assistance of personal trainers or professional guidance, that would be recommended. Resistance training is, as we know, probably the most important activity for the maintenance of muscle mass via physical activity. Resistance training includes a number of activities. I think most people would assume that it means going to the gym and lifting some heavy weights, but that's not necessarily the case. And that adults should do at least 150 minutes a week of moderate to vigorous physical activity. Usually that's aerobic physical activity. But as part of their weekly physical activity, there should be some multi-component aspects, and this would include balance training as well as resistance training. So strengthening activities can take a number of forms. We've got a picture here showing the use of resistance bands, which are becoming increasingly popular and not necessarily even requiring the people's hands. You can get handled bands, and those are relatively cheap. But of course, at the same time, you can appreciate that free weights or dumbbells or equipments at a senior center or even at commercial gyms would serve the same purpose. So I want to emphasize that it's the engagement in strengthening or loading activity that is particularly important for the alleviation or mitigation of muscle mass loss as people age. So strength training is also used as a treatment. And we've got an example here in lower body exercises using a chair stand exercise. And I just want to emphasize, don't click the links to watch the videos, that you can access the videos and additional materials linked on the website. But upper body activity can include lots of things, and it doesn't necessarily need weights. We've got a picture here of a woman engaging in resistance activity using bottles of water. Those might not seem like large stimuli for muscle, but remember, it's all relative to what it is that people can do. So pick a weight that is challenging, not too challenging for an individual, and use effort as a guide. And we've got an example on the far right then of balance activities. And balance activities can obviously take a number of forms, but chair balance or simply moving around a room, standing on one leg, practicing different types of balancing activities, but obviously developing strength in other aspects to allow you to balance in certain scenarios would be important. And if a person has multiple morbidities, health professionals need to set realistic goals that people can be as physically active as their limitations allow. And clinicians should refer patients to physical therapy for further evaluation if needed, and for the development of a physical activity plan. And that's especially patients with multiple morbidities and maybe multiple medication use. So in terms of some patient handouts, we've got some links here again, and I don't want people to click on the links. You can access these resources in the additional materials that are linked on the website. And these are credible sources for handouts to provide patients illustrating at-home exercises. Vivifrail resources for professionals are responsible for the prescription of a program of physical activity. And the U.S. National Institute on Aging provides playlists on YouTube, which are free to download and are extremely useful resources for people not knowing where to get started. So you can check those resources out on the website. I need to talk a little bit about nutrition and dietary intake, and just mention that all nutrition intake should be guided by dietitians, licensed and certified professionals for nutrition counseling and dietary intake. And this is important in the prevention and treatment of sarcopenia. The preventive aspect would emphasize a greater habitual intake of a higher quality diet that is linked to muscle strength and physical performance later in life. This would include the consumption of dietary patterns with nutrient-dense foods that are particularly rich in protein, an adequate energy or calorie intake combined with regular physical activity. The two of these things combined generally have what we recognize as being a synergistic effect on muscle and muscle function. From a treatment aspect, the focus is again on adequate dietary intake and adequate protein intake. And if undernutrition is present, we need to restore nutritional status as a first priority. The recommendations for protein intake are greater than the current US recommended dietary allowance, which sits at 0.8 grams of protein per kilo per day, and are as high as at least 1.2, and probably, I think, would benefit with people going up to intakes of about 1.5 grams of protein per kilogram body weight per day. Recognizing, however, that that may be hard to achieve on low energy intake levels and in people with comorbidities without maybe the use of an oral nutritional supplement. So in certain scenarios, it could certainly be applicable that instead of particularly choosing dietary sources, that individuals could work with clinicians and registered dietitians for the development and monitoring of a realistic dietary plan, and basically to make patients aware of using dietary supplements, as many supplements tend to have claims that are somewhat outrageous and with no efficacy. So I would say that supplements or protein powders or shakes and these sorts of things can be useful in certain scenarios, but they are certainly not necessary. So we want to emphasize a diet-first approach that incorporates nutrient density so that people get not only their protein intake, but all of the other nutrients that they need. So just be careful when talking to patients about the use of supplements. So as a case study, I'm going to introduce you here to Rebecca. Rebecca is a 72-year-old woman who has been referred to a registered dietitian after being diagnosed with sarcopenia. She admits that she struggles with a lack of appetite, which is not uncommon in older individuals, but at approximately 100 pounds or around 45 kilos, the recommendations are that Rebecca should be eating around 54 to 68 grams of protein per day. And it may be that she could use oral nutritional supplements to boost that protein intake that might allow her to compensate for her lower appetite. So the registered dietitian provides a meal plan for adequate energy intake and suggests that foods to meet her daily protein goal are something like as follows. So we have lean ground beef, 3 ounces, which provides 22 grams of protein. We've got pork loin, which at 3 ounces provides 23 grams of protein. Or if Rebecca so chooses, it could be that she prefers a plant-based diet, and this is entirely acceptable. We've got tofu, or about a half a cup of tofu at 4 ounces, providing 11 grams, or around a half a cup of chickpeas or kidney beans or black beans, providing about 21 grams. 2 large eggs provide 12 grams, and one of my own personal favorites, low-fat or non-fat Greek yogurt, provides about a cup of it, around 20 grams of proteins. And so we can get a lot of protein from dietary sources from a number of common foods, but also get a number of other nutrients that are important. So we could, for example, highlight calcium and vitamin D if the protein foods are enriched in vitamin D, for example. Or eggs contain a lot of nutrients that are very difficult to find in other places. And beans and plant-based sources, of course, contain dietary fiber, which is important for older adults' health. So we could get a variety of combinations of foods here that would help Rebecca reach her target that I don't think are too far beyond the means of most older individuals. At the same time, in the current landscape, we recognize that there are no pharmacological interventions that can treat sarcopenia. So we've got some medications that are out there on a limited phase 1, phase 2 trial basis that have been tried. These focus on various receptors, blocking them or antagonizing them, or agonizing certain receptors. But those have shown limited effectiveness. So we're really restricted in the current landscape to the use of lifestyle-based interventions, and particularly exercise and dietary choices. So current clinical trials don't offer a lot of hope in this regard. So there are no currently approved pharmacological agents. So it may be important then for pharmaceutical companies to recognize that the pursuit of pharmacological interventions, though, may be necessary. So we have some classes of drugs developed in what are called selective androgen receptor modulators and anti-myostatins, which are beginning to show promise, but I think we're a ways off before we can begin to think about these as mainstream applications. There's another drug, I think, that's sort of heralding a new phase of what it means to age successfully. And this is the impact of glucagon-like peptide receptor agonist medications. And these are now being increasingly prescribed for older individuals to help them lose weight. These GLP-1 agonists have been around for some time in the treatment of type 2 diabetes, but it's only been recently in which they've been indicated for use both in the United States and in Canada. And I can't speak to other people on the webinar that are listening globally, but surely I think most people will have heard of these drugs. And I think we're in the beginning phase. We're sort of seeing the rising tide of the use of these drugs because for the first time, they offer tremendous promise in terms of regulating appetite and weight loss. So GLP-1 therapy is increasingly prevalent, and because these medications are associated with weight loss, we've known for some time that weight loss or energy restriction also results in muscle loss. The worry, of course, is that the weight loss on these drugs can be rapid and is very effective. That's great for the loss of body weight if it were the loss of fat mass, but not if it's the loss of muscle mass, which may outpace what occurs with normal aging. So it's important to consider the role of these drugs in their weight loss context, but also in the identification and diagnosis of sarcopenia. So as a case study here, meet James. James is a 68-year-old, retired office manager, and he complains of difficulty rising from a chair and walking long distances. He has a decline in overall energy level, and his activity levels over the last year or so have been much lower than he would expect and would like, and he's experienced a weight gain of around 7 kilograms. He's living independently. He has no recent or acute illness, but he has suffered 2 minor falls, which he chalks up to maybe his weight gain. in the past 6 months and an increased fatigue with daily activities. We can see on physical examination that his body mass index at 31.2 makes him in the category of he's a person with obesity. But at the same time, on clinical indication, he also appears to have some muscle wasting or loss in his thighs and upper arms. His gait is somewhat slow and unsteady. And he has a reduced lower limb strength with about a 4 out of 5 bilaterally. And he says he has difficulty with his balance. His HbA1c is 7.2. And on clinical examination of a DEXA scan, it's revealed that he has a reduction in skeletal muscle mass or lean mass, an increased central fat deposition. So it may be that James is at risk of not just sarcopenia, but maybe he's got the confluence, as Dr. Kenny mentioned, of maybe obesity at the same time. So when we look at the assessment then of sarcopenia obesity, the screening process is as follows. We're looking for the presence of both a high BMI or waist circumference or body fat percentage, which we could get from the DEXA scan. And we're looking for surrogate parameters for sarcopenia. Not only the lean mass, which we know isn't muscle mass from the DEXA scan, but that may be indicated as low, but clinical symptoms and risk factors like chronic disease and some sort of trauma or surgery. From a diagnostic perspective, we can look for muscle strength changes, we can look for chair stand changes, and altered body composition that would indicate an increase in fat mass and a reduction in muscle mass. So the confluence of these then is a degree of confirmation that James could be suffering from the dual burden of sarcopenia and obesity. And I think that it's important to recognize that if James were prescribed a GLP-1 drug, which is maybe common in somebody like James who has a BMI as he did and a body fat percentage and probably a waist circumference, that there is an effect or an impact on muscle mass. The usual rule of thumb is that when people lose weight, they lose about 25% of their loss from fat-free or lean mass, some of which is going to be muscle. But with these drugs, we've got ranges of weight loss, fat-free mass loss ranging from at least 20 to maybe as high as 40%. And skeletal muscle mass is probably around 50% of fat-free mass. The problem is right now we have no studies that have reported the effects of these GLP-1 drugs on skeletal muscle and coupled with objective measures of physical function. But a number of researchers have raised as a possibility the accelerated loss of muscle mass. Now, fat mass loss is great. Alleviation of metabolic symptoms is great. That's the target effect of these GLP-1 drugs. But the gap or the concern is that with older adults, less muscle mass at baseline may predispose them for problems, particularly if they decide to discontinue the use of GLP-1s. So people who lose weight rapidly and without the accompaniment of exercise and probably a higher dietary protein intake may be putting themselves at risk. So concurrent strategies are definitely paramount. The recommendation is that older people in particular who are prescribed GLP-1s also be given some consultation with a dietitian to look at increasing their dietary protein intake, and that they should be practicing some form of exercise, and particularly resistive exercise, to prevent muscle loss that can lead to or exacerbate sarcopenic obesity across the lifespan. So recommendations for patients with sarcopenic obesity are as follows. So patient selection or initiation, that all patients prior to being placed on a GLP-1 should be evaluated for impairments in physical function as the outward manifestation that they probably have low skeletal muscle. The treatment choice then is to consider choosing a medication with a less rapid weight reduction or increasing the dose at a slower rate, maybe progressing slower than is recommended, and focusing solely on weight loss as the outcome. The recommendation is for monitoring at least every 1 to 3 months during the ramp-up phase for adverse events. These could include things like fatigue. They could include an increased fall or an inability to be able to do activities of daily living. And the maintenance dose should really be the lowest effective dose at which a weight loss is maintained, and there needs to be less of a focus on driving weight loss to lower and lower levels. And as far as discontinuation, any severe adverse event, obviously, or worsening of muscle weakness or loss of physical function should prompt either medication discontinuation or at least some degree of consultation with the patient about what it is that they are experiencing and whether slowing down the dose or coming off of the drug and seeing what happens would be recommended. But clearly more research in this area is needed. So as far as GLP-1 related muscle loss in practice, if a 60-year-old person who has obesity with 45% body fat and weighs 100 kilograms loses 20 kilograms, which we might be celebrating as a great weight loss goal, or around 44 pounds, then 2 to 3 kilos of that, or around 5.5 to 6.5 pounds, could be muscle mass. And this is consequential when we consider that the normal rate of muscle loss is about 1% or a little bit less per year. So when combined with, that knowledge, I think that when we look at a weight loss or muscle mass loss of around 0.3 kilograms or less than a pound per year, you can see that this is a rapidly accelerated loss of muscle relative to the time span in which the person were on this drug. So it's important to recognize that changes in food intake with dietary preferences on GLP-1s is still unclear. We don't have a great handle on what it is that patients actually consume when they're taking these drugs. We know, obviously, that they consume significantly fewer calories, or energy intake is reduced, especially early in therapy if they're experiencing nausea or other GI discomfort, and the effects of these drugs are on appetite suppression. So a change in food preferences or GI side effects may limit food and particularly protein intake. And again, these are data that we do not have. So we know that the dual burden then of a reduction in energy intake and a reduction in protein intake could adversely affect muscle mass, and particularly in people who are continuing to be sedentary during the use of these drugs. So it will be important to prioritize the use of, the consumption of nutrient-dense, high-protein foods and beverages during this phase, in addition to prioritizing, obviously, either the increase in exercise that these folks would do, particularly emphasizing resistance training, or maybe implementing something if they weren't doing that prior to starting the drug. So with nutrition and exercise interventions, we know that we can improve body composition. So the sort of conventional approaches that we talk about may not apply in a landscape of the use of GLP-1 medications, where we need to think a little bit differently about nutrition and exercise. So the usual approach to weight loss with a low calorie, low energy intake and with aerobic exercise tends to actually decrease muscle mass, and so therefore it's insufficient. So the preservation of muscle mass would rely on these patients increasing the amount of resistance training, or at least mixed exercise, so aerobic and resistance. And high protein should be combined with energy restriction. So again, emphasizing all of the principles that we talked about before, but particularly so in a restricted energy intake environment. But we clearly need more research on GLP-1 drugs. We have a lack of data on what it is that people actually intake when they are taking these drugs. And particularly that would be the case in older persons. We have very few studies in which larger numbers of older adults have been included. And we have no idea about the long-term side effects of these drugs, particularly for individuals who express a desire to take the drug, achieve their new body weight, and then, as lots of patients do, say, I want to stop taking the drug, for a number of reasons, and then regain weight, which is what a lot of the data show, and what that actually means for older people. So it's unclear how the overall nutritional status changes long-term in these individuals, particularly when older people consume fewer calories or less protein. So we don't have what happens with periodic use of GLP-1s due to their high cost on maybe nutritional status or body composition. And we have very limited data on physical performance. This would obviously be the major concern, that if people are losing weight and losing muscle, that it's adversely affecting their physical function. So measures of physical performance are body weight dependent, and so we need to closely monitor these in any upcoming clinical trials. So sort of further than focusing on the following research needs or gaps. So first, we need to develop consensus definitions and methodologies for the evaluation of sarcopenia. We need to look at the development of pharmacological interventions that not only focus on maybe a loss of fat mass, which GLP-1 drugs do, but the maintenance or preservation of lean mass. We need to identify and validate sarcopenia biomarkers. We need to understand the role or the interaction between sarcopenia and other diseases that are prevalent in older people, diseases such as cancer, heart failure, and diabetes. And it would be good to develop a series of best practices for clinical trials of sarcopenia, including indicators, outcomes, and patient selection. It would be great if we had a diagnostic measure that is somewhat easily and conveniently available that would assess muscle mass. And I emphasize that because most tools now that are used, including bioimpedance analysis and DEXA, which are part of the algorithms of a number of sarcopenia definitions, assess lean mass. And we need to begin not confusing that with muscle mass, because muscle mass is a subcomponent of lean mass. And we need to obtain support from regulatory agencies, and I think this is particularly important, and professional societies, to hasten the process of developing pharmacological treatments. And finally, we need better data on the prevalence of sarcopenia in population-based surveys, clinical populations at high risk, including those who are hospitalized and those in assisted living communities. So I think some of the key takeaways for practitioners are that clinicians and dietitians play critical roles in the prevention and treatment of sarcopenia. The prevention and management of sarcopenia should be discussed, I think, with all patients over the age of 65. And to emphasize a point that Dr. Kenny made, it's not necessarily that it's a fait accompli that sarcopenia is part of aging. It's true that all older people will lose some muscle mass, but that it not become problematic. So I think in identifying and diagnosing sarcopenia, we need to make an increasing use of the SARC-F questionnaire to identify at-risk patients. And we need to diagnose using grip strength and gait speed. There is an ICD-10 code available that is out there for use and could be useful for clinicians in prescribing treatment. But clearly, we need to work with interdisciplinary healthcare teams to implement evidence-based prevention and treatment strategies, including strength-based exercise and nutrition. I want to thank you very much for taking the time, and I'm happy to hand this back to Professor Fielding.
Thank you again to Drs. Kenny and Phillips for that excellent overview. I also want to thank the planning group who were instrumental in putting together the outline for this session. Dr. Julia Coletta, Dr. Rosalie Correa de Raju, Dr. Alfonso Cruz-Gentoff, Dr. Johanna Dwyer, and special thanks to the ILSI staff for facilitating and organizing the webinar, Cypress Links and Tasha Karosis. And additional thanks to Nutrition in Demand for their work putting the slide presentation together, and to Partners for Advancing Clinical Education for overseeing the accreditation of this webinar. We'd like to take some time now for a virtual fireside chat. And we have some discussion questions that we want to share. So I think the first one, and I'll direct this to Dr. Phillips to kick it off. Is it ever too late to intervene in sarcopenia?
Yeah, I get that question a lot. I think it's a great question. And, the quick answer is no. I mean, if we go back to some really landmark work in this area, I think the Fix-It trial, which was a study in nonagenarians, so people in their 90s, actually showed that yeah, these were assisted living dwelling folks who engaged in physical activity programs that were mostly done in a chair and using bands and these sorts of things. So very easily accessible, showed tremendous improvements in strength and function. And so if people in their 90s can make progress, I mean, it speaks to the adaptability and the physiology that it is really never too late to start. And I hasten to add, I think that a lot of people are maybe confused, but we know for sure that it's when you take people who are doing little to nothing to doing something, that's when the biggest reduction in risk for just about everything happens. So even a little goes a long way. And I think a lot of people believe that it needs to be some arduous, strenuous physical activity that they're doing, and nothing could be further from the truth. So little pieces help. People are talking about exercise snacks as being the way to do things, little 10-minute breaks throughout the day. And I think that that's really the approach that I would recommend in people who are very, very sedentary to start. But the benefits accrue at any age. So definitely, if you've not started, it's never too late.
Dr. Kenny, any further comments on that?
No, like that again, I think the earlier you start, the better, because you've less ground to catch up on. But there are a number of studies, as Stuart has highlighted, in different levels, patients and people with different levels of disability, both cognitive and physical, which show there is benefit in muscle mass and muscle strength and overall energy levels by intervening with dietary change and physical activity.
Dr. Kenny, is falling inevitable with advancing age?
No, this is another misconception. Now, there's no question that falls become much more common with advancing age. And I mean, in the longitudinal study where we've looked at falls and different types of falls and blackouts, in those representative population sample of those 50 and older, we found a clear age gradient. In other words, a clear increase with each incremental decade, to the point where those over 75, 40% in our community dwelling cohort had a fall in the previous year. However, falls are not inevitable, much like sarcopenia. They occur because of decreased physical activity with advancing age and a loss in muscle mass and muscle strength, which is not sarcopenic necessarily, but is age related. So when I see patients aged 50 and older, my advice is every year after the age of 50, do a little bit more in the context of physical activity, for example, not less. And there's really no such thing as I'm too old for that.
Yeah.
Get that out of your head. And that way, people do not have an increased inclination to falling. People who are fit and adhere to good physical activity regimes, as we've discussed, balance, muscle strengthening, and physical activity, are not fallers. They do not experience falls.
Yeah, I'm glad to hear you say that, because I think sometimes people think falls are typically associated with balance problems and sort of changes in blood pressure, standing up quickly, things like that. But to hear you talk about the idea that muscle strength and the loss of muscle strength is a key factor in predicting who's going to fall versus who's not going to fall, I think is a really important message.
I would add to that, however, because my training is in cardiovascular medicine and cardiovascular research. That's how I got into geriatric medicine. And a lot of our work has shown that orthostatic hypotension, a drop in blood pressure when people stand, significantly contributes to falls risk. However, it's also much more common in those who have muscle weakness, and actually building capacitant vessels, that's the core muscle and lower limb muscles, is one of the interventions we apply for drops in blood pressure when people stand, orthostatic hypotension. So cardiovascular disorders, including that, do contribute to falls, but by far the commonest contributing factor is the muscle.
What about prevention of falls? Are things like, we always hear about balance training, but is things like standing on one leg enough to prevent falls? Or do you remember?
Well, that's one form of balance training, which is very good. And what I like about that recommendation actually is it can be applied to fit into your daily routine when you're washing your teeth, when you're standing at the kitchen sink, which men are doing all of the time, of course. But it can be built into normal routine activities. That's what's important. In addition to specific balance exercise programs, of which actually core exercise, core strength building is very important.
Yeah, I think to emphasize what Dr. Kenny just said, I mean, I think that balance training it's great to practice activities which challenge balance. So, I think if we all stand on one leg or try to strike certain yoga poses, they place us in precarious balance positions. But balance is as much about development of strength and accessory muscles than it is about, practicing maneuvers that challenge your balance. So comprehensive balance training programs incorporate a number of different aspects. There's aspects of strength, there's power as well, so moving quickly and being able to take a step if you are out of balance, and as well as a proprioceptive awareness of your environment and lots of other things. So, audits of people's physical live space to reduce their fall risk, reducing trip hazards and these sorts of things contribute to reductions in falls. But emphasizing the role that physical activity and being stronger and more powerful as you age play in reducing fall risk, I think is critical.
Yeah, certainly things like dynamic activities like yoga poses, for example, both challenge the vestibular system and improve our balance, but also have components that demand some level of muscle strength and muscle performance. So I think it gets at many of those domains at the same time. And then, Dr. Phillips, does resistance training necessarily have to be heavy or high intensity to sort of realize benefits? What do you think about that?
Yeah, that's a great question. I mean, I do spend a little bit of time on social media, enough to hear the, it's got to be heavy message. And I hear that a lot. And, the Physical Activity Center of Excellence that I direct here at McMaster, we emphasize programs of progressive strength training, which don't rely on heavy weights. We use people's rating of perceived exertion as a much more effective guide than just saying it has to be heavy. I think that there are groups of people and people who like lifting heavy, and I have no issues with that at all. But I think we need to draw a sharp distinction between what is needed. In other words, what do I need to do to age well, to preserve my muscle mass and to essentially reduce my fall risk? And the answer is progressive resistance training, but it does not need to be heavy. That's sufficient to alleviate the risks that you just spoke of. But I think at the same time, what's needed is the engagement in resistive exercise. And that's the point I make a lot of times. A lot of people are really sort of into the prescription that's given, and I agree that things have to progress. But I do emphasize that actually, when we look at prevalence of what people are actually doing, a lot of people are pretty physically active, but the incorporation of the strengthening exercise, particularly in older individuals, is far less common. So my point is also to say, well, it would be more important to get people into some form of strengthening exercise. And then once they're in there, we can begin to sort of twist the finer nuances about how heavy things should be. But as long as the resistive workout is challenging and people are rating their perceived exertion as pretty high, so 7 or 8 out of 10, I think that the strengthening program is going to accomplish most of the goals that most people would have in mind.
Yeah, I hear you saying, goal setting is important as well, that,
Absolutely.
you have to decide, talk to people about what they want to achieve,
Yeah.
and then design the program to sort of address those needs. And then what about resources? I have a lot of people talk to me about the idea that, well, geez, I've never done any weightlifting. I've never done any strength training. Where can I get information about this? And I know there's some great information that we're going to provide through our website, but what do you tell people when they ask, what should I do? Should I get a personal trainer? Should I join a gym? What's the best thing if you've not done this before?
Yeah, there are barriers to engaging in strengthening activities. I mean, I would acknowledge that if you say to somebody you need to be more aerobically active, everybody can leave their house and go for a walk, and the barriers are much fewer than they would be to engaging in strengthening activity. But it's great if you have the resources to join a gym and there's a facility and you have a personal trainer. That's great, but recognizing the barriers to maybe economic or resource wise to that. I mean, strengthening activity, we showed the bands that are increasingly, I think, prevalently used and are remarkably effective. The bands come in multiple forms now. They have handles on. You can use the forms that you need to wrap around your hands, no problem. And they're relatively cheap. And you can do a lot of this at home. And I don't think that it should be a, sort of, I need to go to the gym. I need to do this. And you can do these sorts of things. There are lots of free resources. We're providing some here, but lots more besides. And older people would benefit from just about any form of strength training if they're not currently doing it. So very low barriers, I think, to entry that are not economically or resource-wise going to challenge most people, but hopefully something that people would realize that they can do at home if they don't have the resources in their community or the ability/capacity to go to a facility.
I mean, more and more in the United States, and I suspect in Canada too, and maybe other places, we are seeing some community centers that focus on seniors that are offering exercise programs, and some of those are also incorporating some strengthening exercises, at least beginning to. And I think that will tend to continue to increase, and I think those are also low cost opportunities. But I think there are varying degrees of resources available for that. And I think that's important for people to know that they can get help to get started and implement a program. Just turning
Just, if I could just add a few, if I could just add, sorry, if I could just add to that, Roger. First of all, with respect, for example, to sarcopenic obesity, that's got a very sharp socioeconomic gradient associated with it. And therefore, you're not talking about cohorts who would have the resources for personal trainers or regular personal training. And secondly, you are looking at individuals who have never embraced this clearly as part of a lifestyle behavior, health behavior. So they are very often put off by even the concept of muscle strengthening exercise programs. To some of people at that extreme, it's like that's way outside my zone, my comfort zone, my zone of familiarity. So I think anything we advise as healthcare professionals must be tailored to the individual and their socioeconomic circumstances. And the second thing I often recommend is to try and do things as part of a class, strengthening or whatever as part of a class. Pilates, for example, provides class opportunities with good muscle strengthening opportunities and balance through the core programs. And the issue there is if you have not been engaging previously, it just helps to do it with others. And as you've nicely highlighted through those particular senior programs, others who may have levels of disability or issues very similar to your own, which will give you an extra comfort blanket. So they're just a couple of things that I wanted to add to that.
Yeah, that's a perfect segue to my next question for you, Dr. Kenny, is what about people with osteoarthritis and in fact other comorbidities and diseases, is it safe? What exercises can they do? I mean, how do we recommend these to people that have multiple chronic diseases?
So the first thing to say is that actually, if you can employ a program with respect to having osteoporosis, a muscle strengthening program and balance program, etc., ultimately it will improve your symptoms. So that's the first thing. So that's your target. Secondly, of course, it depends on what joints are mostly involved. And they can actually change. So sometimes you may have very bad back pain, at another time it might be knees, etc. So you have to be ready to tailor, again, the program, the exercise program, according to your, I'll call it a disability, your arthritis and the location of the arthritis and the severity of pain from arthritis at the time. There's so many different exercise programs, however, at now that we can employ, again, tailored to the individual, even chair exercises, even supine, lying exercises, which actually will accommodate all the need, all that the muscle needs to stimulate strength, but actually also accommodate the patient's other comorbidities and pain and other symptoms.
Really important message, especially given the fact that many older people have not one, but are dealing with multiple comorbidities and disease burden, to know that they probably can safely and effectively engage in exercise and physical activity.
Yeah.
So Dr. Phillips, how much protein should older people be getting? What do we tell folks, when they're trying to, if we recommend increase their protein intake, what's the number they should be hitting and how should they hit that?
Yeah, look, it's an area of controversy. The recommended dietary allowance or the recommended nutrient intake, I mean, variously speaking, going around the world, it generally sits at around 0.8 grams of protein per kilogram body weight per day. Myself and a number of other individuals, and I think even yourself, Dr. Fielding, have sort of pushed back on that as a number being on the low side. And I'd like to see older people aim to at least 1 to 1.2, and maybe even with higher intakes showing benefits. So I'd like to say that 1.2 is where I would like to see older people aim for. And at those types of intakes, so 1.2 grams per kilogram body weight per day, at those types of intakes, you do have observational data, mostly I will admit, that show that they are associated with better muscle mass, better muscle function, and even improved morbidity and mortality. And so I think that, that's where I would like to see people aim. I think that, it's inevitable almost with aging that people's appetite tends to go down. And so I acknowledge that people eat less, and sometimes that their food choices would have them habitually select lower protein foods. I think that there's also a little bit of a fear around what it is that higher protein will do. And again, I emphasize that the intakes that I'm recommending, so 1.2, are not associated either in clinical trials or observational studies with progressive declines in kidney function.
Yeah, this one always comes up, so I'm glad this
Yeah.
is the question I had on my list, but please, yeah.
I thought I would head it off.
Yeah.
Or declines in bone mass. And, the bone mass triumvirate of nutrients would be adequate, calcium, obviously, adequate vitamin D or vitamin D. And then as a bone supportive nutrient, once you've got calcium and vitamin D dialed in, protein is actually on the list. And then, of course, loading exercise, and it becomes sort of the then the four sides that inevitably improve bone health. So, I think that we're in a phase now where there's a growing or greater acceptance that higher than the recommended dietary allowance or recommended nutrient intake is where we should be targeting for older individuals, at least for physical function, appreciating that the substrate we're trying to affect is skeletal muscle.
And are there any other important aspects of protein nutrition? Should you take it when you're exercising? We hear all these things, time of day. What do you think?
Yeah, I mean, I think that, the big recommendation is around total daily intake. And so let's aim at 1.2. I think that there are subtleties within how people eat their protein across the day, sort of, small amount, large amount, a larger amount at the breakfast, lunch, and dinner time or late day meals. I think it would be more important to sort of balance those intakes. But I think that that's a subtlety compared to let's just try and get people at 1.2. I think, post-exercise, pre-exercise is probably not as important as we once thought, and it's somewhere around the exercise period, either pre, during, or post. But at the same time, exercise makes your muscles sensitive to protein. And so post-exercise is generally the recommendation that if I'm talking to, pretty physically active people, that was when you should focus on protein intake. But I think broad goals 1.2, the more subtle messaging, even balanced, and then maybe post-exercise is a focus, but less emphasis on the last two as opposed to the first one.
Well, Dr. Kenny, just in terms of prevalence and even recommendations about what to do, are there any gender-specific prevalences we need to be aware of, or recommendations in terms of sarcopenia?
Well, it depends on which stage in the lifespan we're talking about. Let's assume postmenopausal female and male of similar age. Generally speaking, men have higher muscle mass and better muscle strength. So women really need to focus on this more. And postmenopausally, women have a more accelerated loss in both mass and strength and are more inclined to increase fat mass. And so therefore, it matters, of course, to both genders, but I think women need to focus even more on muscle strength and balance exercise programs around the menopause and post-menopausally.
So it seems like when I think about sarcopenia, Dr. Kenny, it reminds me a little bit of osteoporosis, but there's so much awareness about, osteoporosis and treatments available and recommendations. I mean, why are we not there with sarcopenia yet?
I think because we as Stuart highlighted and I mentioned, we still need clarification with definitions. That's the first thing. Unfortunately, we don't have a clear diagnostic test. There are biomarkers under investigation, and some of them look very promising, but until such a time as we have more definitive biomarkers and a clear diagnostic test, it's a difficult concept to get across, actually. And now, having said that, pathologically, there are changes. There are very clear changes. You get fat infiltration, decrease in the amount of skeletal muscle, changes in neuromuscular junctions, and even at a metabolic level, changes in metabolism within muscle cells, etc. Inflammatory changes, oxidative stress changes. But those diagnostic criteria are not at all employed widely. They're not at all employed, hardly, except in research scenarios. So that's the main reason I think it's not recognized. However, there is no reason why we shouldn't raise awareness about sarcopenia and make it better recognized, not only amongst the general public, which is terribly important, but also amongst healthcare professionals who are treating a number of different diseases according to their specialty, etc., probably impacting on sarcopenia, certainly frailty, we know that, and yet never address that particular consequence of interventions.
Excellent. And then I just want to sort of wrap us up here, just talking about the sort of the emergence of the GLP-1 therapies and how we need to think about these treatments, because they are revolutionizing how obesity is being treated and managed, how diabetes is being treated and managed. But are there real concerns about the effects on muscle, and where are the gaps in sort of knowledge? I know, Dr. Phillips, you've been thinking about this for a long time, and Do we know, even if you take a GLP-1, does it make you weaker? Does it decrease your strength?
Yeah, look, I mean, I think that basically the opening stanza is you're spot on. I mean, these drugs aren't going away. This is the early phase use, and why of probably a much more widespread use of not just the injectables that we have now, but certainly oral drugs that we will have in the future. And you can probably count in maybe a decade from now at much more effective and very selective in terms of maybe less nausea and more central appetite suppression. So we're living in a new era of, and it must be a revelation for diabetologists and endocrinologists and people who are in obesity medicine to have a drug that is pretty effective. And so that's something to be celebrated. At the same time, myself, a number of other individuals have raised the concern that weight loss is great, and if we view everything through a weight loss only lens being what is important, we forget that you lose muscle at the same time. And so our work in weight loss has really been the old-fashioned way, just restricting energy and doing it through a little bit more exercise, has been on promoting what we call high-quality weight loss, and that will be weight loss with the highest possible ratio of fat lost to muscle preserved. Recognizing the central role that muscle plays in all kinds of alleviation of chronic diseases, everything that Roseanne just mentioned. But I'm also interested in the preservation and association with, cognitive function as well, which is a huge concern with older people, for which we do not also have a drug treatment or, alleviation other than lifestyle. So, in my mind, muscle is a critically important central organ, is important to preserve. Do people get weaker in the short-term trials that we have? The answer is no. In fact, if anything, people's mobility improves because they've lost a little bit of weight. So that's great. I'm concerned about, not just 1 year, 2 years, but 5 and 10 years down the road. And so, the focus that Dr. Kenny put on health span for optimal aging is really critical here. And I think people have to think not just the short term, but the long-term consequences of these drugs. And we don't have data on that. And so clinical trials need to be performed. And I think the companies that are have these drugs under patent and in widespread use are aware of these problems and probably should focus on those types of trials in the future.
And the focus in many of the clinical trials has been largely on middle-aged people with obesity or diabetes. I think,
but these drugs are being prescribed to people in their 60s, and I have endocrinology patients who are in their early 70s as well. So without maybe an appreciation of the consequences, and I think this double burden of the sarcopenic obesity is, I worry about those patients, and so that's something I think just to raise awareness for sure.
Totally agree. And then I think the other issue is that because of the side effects, a number of people, many people on these medications for various reasons, both economic and side effect wise, terminate use of these drugs. And what actually the composition of the weight regain may be, I think very much an open question, and I think also could be an issue.
Absolutely.
Well, I think this is a good time to conclude our fireside chat. I want to thank you both for your participation and for your answers to my questions and our really collegial discussion. So thank you both very much.
My pleasure.
Thank you.